Good. All right, good morning, everybody. This is Amanda Harper, the Assistant Statewide Care Manager Coordinator. For today's materials, as I said, they can be found through our Care Coordination Advisory that can be found on our OPWDD website and at this link below. So please, if you're not signed up for the advisory, go to this link and enter in your email and you'll receive a listserv notifications when a new advisory is posted to our website. The materials for today are listed. Our agenda is as follows. You'll see that there is a change in the order of things. So if you've printed the materials that were sent through the advisory, you'll just need to flip through them accordingly with the order of the presentations for today. Okay, and just to go back for today, we'll have some of our OPWDD hot topics. We'll have a presentation with Allison McCarthy on CFCO, the Community First Choice Option. We'll have a presentation with Albert Pruitt on the Coordinated Assessment System reassessment, so CAS reassessments. And then with Timothy Byer, we will be reviewing FIDA IDD. It's our managed care demonstration and the role of the CCO with the FIDA IDD. So to begin with our hot topics for today, I would first like to reiterate the care manager and provider information sessions that OPWDD has been hosting since the transition to CCO. The links to the materials and the YouTube recordings of these information sessions is available at the link here. The next session is going to be on the 25th of September, and the topic will be announced shortly, and the registration for the information session will be made available at this link so that you can log in. It's not through SLMS. It's all done through our website. All of the prior recordings and materials are available for you. And there is going to be a survey at the conclusion of this conference today, and it's going to pop up in your browser when the event ends, and it will ask if there's any other topics that you would like OPWDD to provide information on. So the feedback that you provide, and we encourage and ask that you do provide us with feedback, but that can also, that can be for future conferences like this, or it could be for information sessions. So please provide any feedback on other topics that you think would be helpful in supporting the care manager or OPWDD provider role for future information sharing. The CCO override and billing training that we held on August 20th is available through SLMS. So I just want to make sure that everybody is aware of the availability of this training, that we had great attendance back in August, and it was targeted towards the CCO staff that have a role with enrollment, transfer, and withdrawal of individuals from CCO in the choices system, and that interface with the billing process. And it goes in depth into enrollment into CCO, how billing should work, what to do if there are issues with billing, and the manual override process in our choices and tab system to correct issues that may occur within our system for enrollment transfers or withdrawal. So if you have questions on those topics, I encourage you to log into the SLMS system, search this OPWDD-CO/O/BO, and look at that training and materials to get more information on that topic, and you can reach out to the presenters with questions that you have from that. And your CCSL, your Regional Care Coordination Support Liaisons, are a great resource for any of the topics that were discussed on that if you need further information or guidance. Next for our hot topics is the revised person-centered review protocol manual, and this is a resource tool for DQI for the person-centered review protocol. So this is available to you as a reference at this link, and we encourage that you go and look at the resources on this page and to look at this manual and the information within it. Our next topic is in regards to messages on the Choices CCO1 enrollment forms and CCO2 transfer and withdraw forms. And again, that's within the Choices system, and the training that I referenced, the CCO override and billing training, also goes into this, but I wanted to make sure to highlight for everyone on this call that interfaces with the enrollment and transfer withdraw processes, that we understand within the CCO that different people have different roles, but when you're working with an individual and family on enrollment and you're noticing that there's any kind of well, when you're working with enrollment, you want to make sure initially before submitting this enrollment form, the CCO1, that somebody has met all of the enrollment requirements. But when that is submitted and there is a message on that form with some type of an exception, whether it has to do with their level of care or their Medicaid status, that there is a system for follow-up to ensure that any errors that are identified on that form, that you're checking them, that the intake staff that you're working with are checking them and making sure to address them so that it does not cause a delay in somebody's enrollment or any transfer issues. If they're trying to go from one service to another and an error is identified, it could cause their enrollment to end, and then they don't enroll in that new service you're trying to transfer them over to. So I just want to highlight that people are making sure within the enrollment transfer and withdraw process that the messages that are populated on the CCO1 or CCO2 form are being checked and resolved. All right, our next topic is just to make sure everybody is aware of ADM 1906. This is service documentation for support brokerage services. Just want everybody to take the opportunity to review this ADM and the piece about the required life plan documentation for this service for self-directing individuals. Next is the amendment to 14 New York CRR subpart 636-1, the person-centered planning, care management, home and community-based services regulation. It's available at the link below. Just to be aware of the amendments to the language to reflect care management and care coordination organizations, and to make sure that you are familiar with the information in this regulation. Next agenda item, the life plan meeting. Just want to highlight that there, when you are hosting a life plan meeting and when you're coordinating the information leading into the life plan meeting and walking away, that there is agreement with all members of the care planning team so that members of the care planning team can begin developing their service documentation, so that all parties are walking away with agreement, so that a broker or a residential provider is able to begin that staff action plan and to start working on those provider assigned goals as soon as possible with the people that they support. Again, if somebody can make sure that they are muting their line, we're still getting a little bit of feedback. Okay, so we are going to get started with our next presentation, and I'm going to come back to the hot topics because we do have a little bit of a time crunch today with some of our presenters. So we're going to put a pin in the life plan meeting and come back to this at the conclusion of our FIDA presentation. So we're going to mute for a moment, and then we will be starting our CFCO presentation. Okay, so we're going to begin our CFCO presentation. Welcome, Allison McCarthy.
Good morning, everyone. Thanks for participating. Want to just take an opportunity today to talk about the Community First Choice option, otherwise known as CFCO. The CFCO implementation, which is a broader statewide implementation for under Medicaid long-term supports and services, is scheduled to occur on January 1, 2020. So previously we were looking at different implementation dates at this point in time. The target and anticipated implementation date is January 1, 2020. Now, before I get started into the presentation, I just want to back up and make sure that as care managers and as care manager supervisors, there's an understanding that community first choice option is not anything that will impact the individual. It does not change the service. It does not change how the service is delivered. It does not change how the service is coordinated for the individual. What it is doing, it is changing the authority, the Medicaid authority by which the service is authorized. So what does that mean? That means that when we negotiate with our partners at the federal government, they have two ways of approving the expenditure of Medicaid dollars. So Medicaid services can be delivered through two different authorities, a state plan authority or a home and community-based services waiver. I think many of you are familiar with the home and community-based services waiver because OPWD, as you know, has a very large comprehensive waiver that most of our services are funded through. Now, the state plan authority is a different type of authority, and typically it is available to all individuals who are eligible for Medicaid. So let's just drill down into that a little bit more. So as you're familiar with, our HCBS waiver allows states to waive certain Medicaid program requirements. So for OPWD's comprehensive waiver, we have a targeted waiver that is targeted to individuals with developmental disabilities. So you must be developmentally disabled and have a level of care that meets the OPWD mental hygiene law standard. So it is a time-limited waiver, so we have to renew our waiver every 5 years. And as you may be aware, we're currently under a negotiation with CMS to renew our current HCBS waiver effective October 1, 2019. So it's an ongoing negotiation that must be renewed every 5 years. We also have a certain number of recipients who are authorized to be served under that waiver. So that is something else that we continually to negotiate and work with CMS to agree to what that number looks like. On the other side, we have a state plan authority. So state plan authorities must be available to all eligible Medicaid enrollees. So it's not just limited to the developmentally disabled population, it's also eligible to all Medicaid enrollees. For example, someone who has a traumatic brain injury who does not qualify for OPWD services would be eligible for a state plan service because they're eligible for Medicaid services. So somebody who has a TBI would be eligible to receive community first choice option. The state plan does not expire, so you don't have to go back and get that renewed every 5 years, and there's no cap on the number of individuals who are eligible to receive that service. So why does that matter in the context of CFCO? So community first choice option is a state plan option. So what it really does, it offers services that have historically been available only to individuals who are enrolled in an HCBS waiver and expands that to the general Medicaid population so that all of those individuals have access to those home and community-based services waiver. So what that means is CFCO is really an opportunity for the broader Medicaid population, but why it's important to us at OPWD and you as care managers is because it will impact the way we work. It will not and should not impact the individual in the service, but we need to understand how it impacts your day-to-day activities and, really the life planning process and how services are authorized. So today I want to take a few minutes to really introduce those concepts. It may not make complete sense in one presentation, so I encourage you to review the slides following the presentation, and what we've asked is that each CCO identify a CFCO liaison, and I would like those CFCO liaisons to be the point of contact within your CCO to receive questions from you and to communicate with us at OPWD to clarify those questions. What I've learned through this CCO implementation process is that when we communicate across the aisle, back and forth between OPWD and care managers or care manager supervisors, sometimes we're not taking the opportunity to educate the complete and full staff at the CCO so that information and education can be shared across the entire organization. So I find that if we have a designated liaison to provide that communication, we're often more effective at sharing and educating across the organization. So let's drill down a little bit into CFCO. CFCO as a state plan authority, allowing states to offer home and community-based services to eligible Medicaid enrollees. Again, it expands access to certain services to support and help individuals with their everyday lives. So who is eligible for CFCO? In order to be eligible for CFCO, you must have regular Medicaid. So what that means is that an individual who has regular Medicaid will be eligible for CFCO. A person who may not have or who does not have regular Medicaid is an individual or a child who is eligible for our HCBS waiver through parental deeming. So those individuals who are eligible through the OPWD waiver through parental deeming are not eligible for CFCO. An individual must also have an institutional level of care to be eligible for CFCO. So whether it's ICF level of care, nursing level of care, that is a requirement for eligibility in CFCO. You also must be living in your own home or a family member's home. So if you're living in a certified setting, you are not eligible for CFCO. It's a community-based program and service, and you must be living in your own home or a family member's home. So I'm going to pause there and just also really highlight that what CFCO also does not include is budget authority. So individuals who are in our HCBS waiver and who are self-directing with budget authority, they are not eligible. It's not included in CFCO. So that's an important point. If you're coordinating care for an individual who is self-directing, CFCO does not come into the picture because there is no budget authority under this state plan option. So let's take a look at what the CFCO services are. So you'll see on this slide a list of services. The services that are in the dotted line box, which actually should come all the way up above assistive technology, so we'll correct that. Those are the services that you all know and love. Those today are in Section 4 of the Life Plan, and those services will continue to be in Section 4 of the Life Plan and are our OPWD services. Now, if an individual is eligible for CFCO, on January 1, those services become state plan CFCO services. So again, it does not impact the individual or the service, but how that service is authorized through the Medicaid authority changes. And I'll talk about why that's important in terms of service authorization in just a moment. So you'll also see on this slide the additional services that are traditional state plan services that are also part of the CFCO service array: personal care, home health care, CDPAP, personal emergency response, home delivered meals, and durable medical equipment. So today, those services are available. Many individuals who are OPWD eligible and enrolled in our waiver receive those services. What is interesting is when we transitioned to CCO last year, we trained on the Section 4 of the Life Plan and how we reflect OPWD services in that Life Plan. Now, we actually have a very important opportunity here because for these non-OPWD services, in order to think about these in an integrated way and make sure they make sense in the comprehensive life plan of the individual, we can really start thinking about, well, you know, how does this work for the person? Does the person receive personal care? How does this interrelate with any other OPWD service they're receiving? So it's really challenging us as a system and as care managers and CCOs to think more broadly beyond the OPWD services and to consider how these services are reflected in the life plan. Now, I will be honest to say we don't necessarily have, for this presentation, the detail drilling down to how each service is reflected in the life plan. That is coming. We're working with our partners at Department of Health to understand and assess how that should be reflected. So that will be coming shortly. So when we think about overlapping CFCO services, so those are the services that are both in our HCBS waiver as well as in CFCO. For people who are enrolled in the waiver, there are two different approaches. So there's people who are enrolled in fee-for-service, and then there's individuals who are enrolled in managed care. For example, if an individual, we have 25,000 individuals who today are enrolled in mainstream managed care, so they're enrolled in Fidelis or Aetna, and why this matters is because on January 1, the CFCO overlapping services actually become part of that managed care benefit package. So that managed care plan will be responsible for authorizing those CFCO overlapping services. For somebody who is enrolled in fee-for-service, it doesn't change. The DDRO will continue to authorize the OPWD overlapping services like they do today. Now, just to step back for a moment, people who are not enrolled in the waiver can access CFCO services via the New York State plan. So an individual who enrolls in the CCO, they may only need community hab or personal care. Those individuals do not need to enroll in our HCBS waiver. They may be able to be served through the CFCO state plan option without going through that waiver enrollment process. So that's just an important note. As CFCO does come online and community hab, EMOD, VMOD become part of that benefit package, unlike today, it may make sense or it may be appropriate that they are served through that state plan Medicaid option and the process for waiver enrollment does not need to occur, which, you know, is a good thing because it's, you know, less administration and less processing for you, the DDRO, and anyone who's supporting that activity. So let's just take an example of community habilitation. If I receive community habilitation today and I meet CFCO eligibility, so I live in the community, I'm not self-directing, I have regular Medicaid, I think that's it. So, you know, so I meet CFCO eligibility, that means I will receive SAME, which is community habilitation, and I missed that point on the previous slide. Community habilitation in the CFCO state plan is called SAME, which is Skills, Acquisition, Maintenance, and Enhancement. So that SAME or community hab service would be funded under Community First Choice option. If I receive community hab today and I do not meet CFCO eligibility, so maybe I am a child who's been deemed eligible through parental deeming, that would mean I'm not eligible. If I'm self-directing with budget authority, that would mean I'm not eligible. Or if I am living in a certified setting, I am not eligible. So I would continue to receive community habilitation under the current home and community-based services waiver. So what does that mean? What does that mean in terms of service authorization for CFCO services? As I mentioned earlier, if you're receiving an overlapping CFCO service and you're enrolled in fee-for-service, OPWD regional office continues to authorize that service just like they do today. If you are receiving a different type of CFCO service, so a non-overlapping service like personal care or home health, the same process occurs if you're enrolled for fee-for-service today, that the same process occurs where the local Department of Social Services authorizes that service. So the LDSS authorizes the personal care, and you as the care coordinator or care manager need to confirm that service authorization has occurred in order to finalize that life plan. For CFCO services, for anyone who is enrolled in managed care, the managed care plan will authorize that service. So what we really need to do is break down that process and work with managed care plans to determine a process for communication between the CCO care manager and the managed care plan. Now, we're currently in discussions with our managed care community of practice group who is supporting this work and supporting the flow of information. We are discussing the use of secure emails prior to the use of potentially the CCO portal once that's up and available for sharing life plans and communicating information about service authorization. So again, not all of the I's are dotted and T's are crossed in terms of how it will work on January 1 and beyond, but we're working collectively with our managed care community of practice group to have conversations with the managed care plans and their association to confirm what this process will look like. You should also know that your CCO liaisons and executives are also engaged in the conversation, and we have work to do to nail down what this process will look like. But again, for today, the life plan that you're using meets the needs of HCBS services, so that's very positive. It's a life plan that includes the elements that support the billing of the service, and it really has the capacity to include all the services that are in the CFCO service array. So it will support our continued development of the CCO model and really support our syncing and full integration of services across both OPWD and DOH state plan services. So in terms of the service and planning process for community habilitation and what we're calling skills acquisition, maintenance, and enhancement, or SAME, nothing really changes. The goals and valued outcomes identified in the life plan will continue to be important and supporting the HCBS rules. So I think, you know, again, the capacity for the CCO and the life plans that you're using today continue to support and substantiate what is needed to support that HCBS service. A staff action plan describes how staff will support achievement of goals and valued outcomes. Staff deliver and document services in accordance with the staff action plan, and every 6 months the staff action plan is reviewed. What is achieved, any needed changes. So the process that you have learned and embraced continues to be the same for any CFCO service, specifically on the community hub, same side, there was no variation. So just to talk about community habilitation specifically and the service authorization process, OPWD stakeholders have requested greater consistency across the state in the process for authorizing services. So as you know, in sitting in a CCO, it may not always be consistent how that process occurs between you and that regional office process. What we're trying to do, based on stakeholder input, and given the fact that CFCO is now broadening who CFCO services are available to, we're really trying to look at instituting a consistent process to ensure that all individuals are being reviewed in a consistent way and their needs are being reviewed in a consistent way, and that for overlapping services, they'll be authorized appropriately by a managed care plan for an individual who's enrolled in managed care. So what we have done is we've developed a service authorization guidance document. That guidance document will describe the most appropriate service levels for different subgroups of individuals based on age, living situation, and individuals' needs. The typical approval ranges within the guidance can be exceeded with clinical justification. So in no way is the service authorization guidance a limit to what an individual can be authorized. What it is doing is providing a tool for care managers, for the regional office, and for managed care plans to have a tool to look at what is appropriate for individuals based on their age, living situation, and individual need. But if there is a need, a clinical need or a behavioral supports need that is above and beyond what is typical, it is in no way a cap, it is just a guideline. So clinical justification can support the authorization of needed services for all individuals. Each person's authorization is still individually tailored to meet his or her need. And again, the regional office will use this guidance at the front door to determine service authorization. This guidance will also be shared with managed care organizations and the local Department of Social Services so that they all have the same information to base service authorization on, and it's happening consistently across the state. OPWD will provide care managers training on the service authorization process in the coming months. So again, as I mentioned, we are taking this opportunity today to just level set what CFCO as a state plan option is, what that means in terms of what you do as care managers today, how it will impact that process, how it does not impact the individual on the delivery of services, but how it will provide opportunities for consistent service authorization as we launch CFCO on January 1st. So just to back up and talk about what this means for you as care managers, what will be important to know as a care manager is if the individual is enrolled in a managed care plan and whether the individual is eligible for CFCO. So in a discussion earlier or last week, with your CCO or CFCO liaisons, so each CCO has a CFCO liaison, which we can share that list of liaisons with you. We recommended to that group that the life plan includes the name of the managed care plan that an individual is enrolled in, as well as the CFCO eligibility code. So that can be information you, as a care manager, don't have to find and look for. It will be on the care plan. It actually comes from the Medicaid system, so it's coming from the source system and can be available so that as you meet with the care team, you talk to providers, you know if a managed care plan representative needs to be considered through that care planning process, you have that information at your fingertips. So again, just want to reiterate, the eligibility criteria is institutional level of care, residing in a community-based setting, so does not reside in a provider-owned or controlled residential setting, and is Medicaid eligible, not based on waiver of parental deeming and not based on spousal budgeting. So again, important to understand what that criteria for CFCO is. The hope is to have that information displayed on the life plan, so you, in the process of working with the individual and the care team, have the information you need to have relevant discussions around service authorization, and then whether the person is enrolled in a managed care plan will be an important piece as well. So more to come in terms of our work with your CCO liaisons and executives, with the managed care plans, and with communication with providers on how that conversation and that communication of information is shared between the CCO and the managed care plan beginning January 1. Just to put things into context, although we do have 25,000 people enrolled in mainstream managed care, there are only about 5,000 individuals today who are receiving community HAB and enrolled in one of those mainstream managed care plans. Data is being shared with the plans with providers, and we hope to be able to communicate the same information with CCOs to give you a clear sense of who is enrolled in a managed care plan, and who you need to think about differently come January 1 when that life plan needs to be finalized during the next annual review meeting. So for additional information and education on CFCO, here is a website. For questions, I think we would encourage you first to reach out to your CFCO liaison and filter any questions to the liaison so they can work directly with me and our team here at OPWD to clarify and develop future trainings. I do hesitate sending your questions in directly to our mailboxes without going to your CFCO liaison and care management director, because this is an education process. We're all learning as we go, and we're learning together, and the more we can consolidate questions and identify what those questions are and work across the table at a higher level, I think the more effective we can be. So I do appreciate your time and your attention, and we will see if we have time for some questions.
All right, so we're going to mute for a moment, and we will be right back.
Hi there. We did receive some questions. I'm going to try to address some of the hot topics that came in through questions. One of them was related to age. Are there any age requirements for CFCO? The answer is no, but that leads to the question of Medicaid eligibility and regular Medicaid rules. We will be providing more content related to what regular Medicaid means. It is a complex area, as you know, so rather than me try to address it here, I will be sharing specifics related to what regular Medicaid and what non-regular Medicaid means, so that we can just get that down on paper and you will have that as a resource. There was a question related to historical services and whether an individual can continue to receive community HAB if they were receiving it before. Yes, service authorization related to CFCO implementation will not change. Just like it happens today, a person's life plan is reviewed on an annual basis, and at that time, through the person-centered planning process, the individual and their care team need to assess the ongoing need and continuation of the service. So that process will continue to be the method for making changes to that care plan and that life plan. Just want to clarify that, so if an individual today is enrolled in a managed care plan and they do not receive OPWD services at all, CFCO services, including community habilitation, will be available come January 1 to that individual. So you do not need to access any OPWD services to be eligible for CFCO, and it will be an opportunity for individuals who are Medicaid eligible to expand the array of services they have available. And I think, when people ask, well, why are we doing this? What's the point of CFCO? It's just that. It expands the service array and the availability of home and community-based services to all Medicaid eligible individuals across the state of New York. Remember, I mentioned that person with traumatic brain injury. Today, an individual who has a TBI does not have access to community HAB necessarily. So the good news is on January 1, that service becomes available, and they can have that community-based support that they've not been able to access previously. And that is really, this comes from a federal initiative to say we recognize that, community-based services and alternatives to institutional care are our policy objective, and we want to be able to encourage states to use this authority to offer those services to individuals in need. So just want to also clarify, if a state plan option, a state plan service, so a CFCO service, if you are available or if you are eligible for that service, that is the first option. So state plan services are accessed prior to a waiver service. So if you are eligible for CFCO on January 1 and you have community habilitation in your life plan, that service is authorized through the state plan and not through the HCBS waiver. So an HCBS waiver service is available after that CFCO state plan service is accessed first. And these services cannot be occurring at the same time. So any service that's included in the CFCO service array cannot be delivered at the same time as another service. So with that, I think I'll pause to take a look at any additional questions, and we'll be right back.
Okay, we did get a couple more questions. One of the questions was, when does the life plan need to be updated for people who are going to be receiving CFCO services?
So our hope is that we will be able to maintain the annual life plan review meeting date as the point in time by which services would be reviewed and approved. So the goal is that it does not change in terms of the annual life plan review date. Come January 1, nothing has to change and no plan has to change for at least 90 days. So what that means is nothing will change for any plan in the system prior to April 1, 2020. Now, our goal, and we're talking with DOH, our partners at the Department of Health, about this option, is to, for anyone who's enrolled in fee-for-service or in managed care, to continue to use the life plan annual review date as that date by which those services would be reviewed and reapproved.
Okay, and the other question that we received was, can you explain how care managers would go about enrolling or signing people up for CFCO?
So it's a good question, how people need to be signed up for CFCO. So today, individuals in the Medicaid system are already flagged as CFCO eligible or not. That information is actually in your CCO's care coordinate system. That information identifies a person's eligibility or not. So nothing needs to happen, but what we are encouraging CCOs to do is to include that information in the life plan so that it is transparent to you and to the care team who is developing and finalizing the care plan. So again, it's already denoted. The system actually flags an individual's eligibility based on the factors that we discussed, including where an individual lives, whether their level of care, if they're self-directing or not self-directing. So the good news is this initiative has been in development for quite some time, so we do have the systems in place to flag the eligibility of an individual already. You know, and I just want to touch on the care plan again. Today, Section 4 of the care plan, you guys are, I think, well-trained and are having success at identifying the OPWD HCBS services on that care plan. We will continue to dialogue with Department of Health to confirm the integration of the non-OPWD CFCO services into the care plan. At this point, they're on Section 5, I think, in most cases. We definitely will continue that practice. The goal is to begin integrating those into Section 4 of the life plan so that we look broadly across the full array of services that an individual receives, and the full care planning team is aware and thinking about that full comprehensive look of services. So again, information will be forthcoming related to any changes to or any change in guidance in the completion of that life plan. Okay, we're going to take a few more questions.
One of the questions we received was, does the level of care determine how many hours of services will be offered?
So the question was whether the level of care will determine the number of hours. The level of care does not determine the number of hours. I think you will see in the coming weeks when Department of Health does share the Community Hab Service Authorization guidance that the guidance for that specific service is broad and, again, looks at the age, the living situation, and other factors about the individual to provide a typical range of services that an individual would be most likely to receive. Clinical justification can certainly support the authorization of services above that range. So again, it's not specifically tied to the level of care determination. So thank you for that question.
Okay. Another question that came in is, will a person from a staff person from a current waiver provider be able to deliver both SAME and Community Hab at the same time to a group of individuals?
So it's a good question. Just to back up a little bit, OPWD Community Hab providers who are currently today acknowledged as providers of OPWD Community Hab will be able to deliver CFCO services and are approved to deliver CFCO SAME services. Whether it's SAME or Community Hab, it's the same service. It does not need to be recognized as any different. And our existing Community Hab ADMs are under review and revision to reflect the expansion of CFCO. So again, more will be forthcoming in terms of how ADM, the Community Hab ADM, is updated to reflect the CFCO service array.
Will care managers still be able to meet with an individual while they're receiving CFCO services, at the same time?
Absolutely. So again, I think we always want to encourage the participation of a care manager while they're in the community receiving community habilitation or SAME. I think it's a terrific opportunity to really assess and talk to the individual about how things are going, and that will not change. Thanks again, and I think we are on to the next topic.
Thank you very much, Allison. That was a great presentation, and I just want to make sure that everybody is aware that we are recording these conferences and that they are posted to the website. So we still have March and June up from our last conferences, and this will join that. So I mean, this was great information on CFCO, and so that everybody is aware, it will be recorded and posted to the website, so that if there are staff members that missed this that you think should hear it, or if you want to go back and re-listen to pieces of this, it will be available. So I'm going to mute for a second, and then we will resume with our next presentation. Okay, so again, this is Amanda, and we are going to go back to where we left off on the hot topics. But I wanted to make sure that with the time that Allison had, that we made it through all of our CFCO content. So we're going to go back to the hot topics where we left off, and then in about 5 or 10 minutes, we will begin our CAS reassessment presentation. So thank you again, Allison. Okay, so where we had left off on the topic of life plan meetings and coming to an understanding and agreement of what the provider assigned goals are going to be. I just wanted to make sure that I didn't move off of that too quickly, so I'm just going to revisit that to reiterate the goal with the life plan meeting is that there's preparation with all team members beforehand to meet and plan with that individual to determine what it is that they would like, what they want, and what they're planning for the upcoming 6 months to a year. from all of their service providers and stakeholders and what their goals are going to be, and that at that life plan meeting, people are coming together and are walking away with a level of agreement. So when we think back to the old world, there was lots of different tools that people used in the form of notes and draft ISPs and what have you that are agreed to with that care planning team, so that people could walk away with a tangible understanding of what they're going to be working on, so that people can get started on their service documentation. So I just want to emphasize that is the goal of the life plan meeting, and that we don't want to be causing undue delay in people being able to start their service plan development. The next item is transferring a program code or service within the same CCO and choices. So this goes back to some of the functions that we've talked about within choices, and again, the override and billing training that was done. A common issue that has come up, and so it was felt that it would be valuable to discuss this statewide at this conference, is when somebody is changing their service or their program code within the same CCO, that there's been some issues with that happening smoothly in choices. So I just want to re-emphasize what that process should be for the people that this impacts. If you have somebody that is choosing to go either from the health home service into the Basic HCBS Plan Support, or vice versa, basic into health home, it's just, that action is just done on the CCO2 form, and you go to the specific part of that form where you indicate that it is a transfer within the same CCO, and you select that service that the person is changing to. You do not go in and complete a CCO1 to add the person to that service if they're making a change within the same CCO. That will create an error in our system, and you're not going to be able to process that transfer, and it's going to delay the action and require manual action on our end, where you'll need to contact your CCSL and have that corrected. So I want to emphasize that within our choices system, when somebody is choosing to either change their service within the same CCO, or you're changing their program code because they have moved and they need to be in a new program code to reflect where they're now living within the same CCO, it's only done on the CCO2 form. You indicate on that form what the transfer is, and again, make sure that you're checking those messages to make sure that the person's, as they are disenrolled from one and enrolled in the other through that CCO2 action, that you're making sure that there's no errors that are going to prevent that from processing effectively. So we'll pause to see if there are any questions after we go through this next policy manual update item. So the information on our policy manual updates is on the next slide. We've included this with each of our slide decks for this conference to make sure that when you are, because hopefully everybody is frequently referring to our CCO policy manual, and that we're doing it from the OPWDD page, that we're not going directly to the DOH page, because you need to be reviewing those posted policy updates on the OPWDD Care Coordination Organization page. And you'll note that since our last conference, we have 2 policy updates that are now posted. So the CCO policy update memorandum that was revised in August, the revised memo from last September, is going to reflect those updated dates for the transition, so you'll be able to see the accurate updated dates. And then the next one is the CCO policy update, CCO referrals and transitional services for individuals in excluded settings. And I really encourage everyone to review that and to understand that information and how to support people that are moving in and out of these excluded settings such as nursing homes, hospitals, jail or prison. So please make sure that you're reviewing and that you are familiar with that information. So, okay, we are going to pause for a minute to see if there's any questions and to get set up for our next presentation. Thank you. Okay, so we're going to move on to our last hot topic items before our CAS presentation that we'll be beginning shortly. And we're going to discuss important actions with when somebody is leaving your CCO. So there's two different actions. Either somebody is withdrawn from your CCO, and we'll talk about what that means, or somebody is disenrolled from your CCO, and we'll talk about what that means. So I'm going to go through these slides, and it's specific to when someone is leaving your CCO. So our first slide has to do with voluntary withdrawal from CCO, and this is information that is all reflected within our policy manual and to that link with the information sessions that is on the Hot Topics page. There's been several presentations within those information sessions that also speak to this. But this is a high-level review to make sure that everyone is on the same page with this information and has a good understanding. And again, we can have some time for questions if there are any questions on this information. So with voluntary withdrawal, the reasons for somebody to be that fit within what constitutes as a voluntary withdrawal is transferring to another CCO. So if somebody is leaving your CCO to go to another CCO, transferring from the CCO Health Home Care Management to Basic Plan Support, so they are signing the appropriate documentation to leave one service to enter into another within your CCO, and withdrawing from enrollment in CCO Care Management Services. So they are choosing to no longer receive any care management service from OPWDD. And to note with this asterisk that this disenrollment reason is placed in queue and choices for the DDRO verification approval. So you'll see when CCO2s are submitted for that reason, the status of that is going to be submitted versus processed, and that that has a separate process through the DDRO to go in and verify that the person does in fact understand what that means to completely withdraw, and that they don't have interest in any other care management service or any other issues that can be mediated and resolved to be able to maintain their care management service. So the appropriate steps for the CCO to take when somebody is voluntarily withdrawing from CCO is to first have somebody sign, to have the individual and their family legal representative or guardian to sign the withdrawal of consent. So that's the DOH 5058 or the DOH 5202 for children. So making sure in these instances, when it's a voluntary withdrawal, so for the reasons listed above, that you have this consent on file. Also, when you have somebody sign this consent, from that date, they have now withdrawn their consent for sharing information and for enrollment in your CCO. So it is imperative that you have them sign the authorization for release of health information pursuant to HIPAA for CCO transfers, so that you can continue to support that person through sharing the required documentation with their new service provider to ensure continuity of care. So you need to have that HIPAA form on file to be able to share relevant documents to assist with the transition and continuity of care. You need to inform the individual that eligibility for waiver services will end if they are not enrolled in a care manager service. So they need to understand that if they're no longer enrolled in a care management service, they will no longer be able to receive OPWDD waiver services. At that point, you can process the CCO2 form in choices to begin the process that will take them out at the end of the month. Please note that if somebody is transferring to another CCO, that there is that collaboration with their receiving CCO that there is a CCO1 submitted for that person to ensure that there won't be a gap in services, that there's collaboration for an enrollment the first of the following month that they disenroll from your CCO. The last piece is to generate the DOH 5235 NOD, and this is uploaded to Choices. So every NOD for these situations should be uploaded to Choices and sent to the individual, the parent, guardian, representative, and also notifying the DDRO. So the DDRO should be notified when this occurs. Okay, so we now have our presenter for CAS, so I don't want to hold that up, so we're going to come back to our next reason, the disenrollment from CCO, once we are done with our presentations with the CAS and with the FIDA IDD. So I apologize for skipping around. I just want to make the most of everybody's time and make sure we get through all of our content. So we're going to pause for a moment and go forward to our CAS presentation, and then we'll have our FIDA presentation, and we'll conclude with these final slides on disenrollment from CCO and field any questions that people have on this topic. Okay,
morning,
so we have Albert Pruitt with us, the Assistant Director for the Bureau of Assessment and Oversight and Coordination, to present on the CAS reassessments. Welcome, Al.
Thank you, Amanda. Today we're going to talk about some next steps with the Coordinated Assessment System and reassessment implementation for this month, September. So thank you all for calling in today. Amanda, can we flip to the next slide? I'd like to start by just providing a couple of definitions for you for how we talk about assessment. The assessments that OPWDD and those on behalf of OPWDD have been completing since April of 2016 have been the initial assessments, and these assessments are completed for a person when he or she is deemed eligible for OPWDD services, and this is the first time that the person is receiving a CAS assessment. So we've been working to complete assessments for all the adults who are receiving OPWDD services since April of 2016. We are also currently completing the initial assessments for those newly determined eligible adults. So our work process then and workflow is that directly following a decision of programmatic eligibility for OPWDD, the person with their eligibility notification letter is also receiving a CAS notification letter and additional information about the CAS. And then our operations team is reaching out to begin the scheduling process. And for those newly determined eligible, this will result in a CAS being completed in line with CCO registration, enrollment, and the ability for the care manager to have the required functional needs assessment available to them to help inform the development of the care plan. The second type of assessment is routine reassessment. So this is what we're working on implementing this month, and we plan to begin reassessment for those who had CAS first completed starting in 2016, prior to CCO implementation. We know that in 2016, we implemented with those residing in residential settings first, so that's important to note. This implementation of routine reassessment will not result in any change in the role for the care manager. So routine reassessment is a comprehensive reassessment that will occur at specified intervals during the course of services. We are working to be in compliance with having reassessment completed on an annual basis. The third type of assessment I'm going to talk about today, and really this will be the focus of this portion of the presentations, is reassessment for significant change in condition. A significant change can be a decline in a person's behavioral or medical condition or functioning that has occurred since the last assessment and prior to the scheduled reassessment. A significant change will not normally resolve itself without intervention by staff. That means it's not self-remitting. It impacts more than one area of the person's medical, health, or behavioral status, does require professional review and/or revision of the person's care plan, and results in a newly identified need for enhanced direct support and/or clinical hours to address the increase in oversight and/or supervision needed to maintain health and safety. So I'd like to provide an example for you to help illustrate a significant change in condition that would result in a decline in the person's behavioral or medical condition or functioning. One example is that the person has experienced a significant injury, such as a fractured hip, and did not fully recover and was not able to resume normal activity, which has resulted in an increased support need for instance, ambulation. In this instance, there would be supporting documentation that would be available to speak to the medical condition, but also the outcome following the recovery from that event. Next slide, please. We also have significant change in condition that can be an improvement in a person's behavioral or medical condition or functioning. And this again would have occurred over since the last assessment, and these are the last CAS assessments, okay, and prior to the scheduled reassessment. In this instance, it would still result in a newly identified need, only it would be for reduced direct support and/or clinical hours to address the decrease in oversight and/or supervision needed to maintain health and safety. And a quick example for you is that a person may require a particular level of staffing for health and safety as related to behavior. The person may have recently been stabilized by medication, and so not in need anymore of that enhanced staffing level for support. And in this instance, we would want to also work to complete a CAS assessment to accurately reflect that improvement and decrease in need. So this would also be supported by documentation. We would have information available to us to understand the person's behavioral needs prior to the improvement being realized, as well as documentation from the appropriate clinicians to understand what intervention resulted in this improvement. So for significant change in condition, both improvement or decline, the role of the care manager is to notify OPWDD. And I guess, again, it's really important to reiterate that these changes are since the last CAS has been completed and prior to a normally scheduled reassessment. While we are working to catch up on reassessment for those CAS assessments completed in 2016, we welcome you to reach out to us and let us know if a person who currently has a CAS in the system has experienced a significant change in condition, regardless of whether or not it's within the defined interval that I've provided, and we'll work to see if the person is meeting the criteria or if we're able to simply move them into queue to have a reassessment completed. We will ask the care managers to notify us if a person is believed to have experienced a decline or improvement, and also provide us with the supporting documentation to understand the qualifying event. On this slide, you have a list of qualifying events to help guide you in your decision making. I won't read through all of the details here, but it's important to know that these qualifying events can be related to accidents or events resulting in serious personal injury. The example I gave you for a person who's recently fractured their hip could be a good example here. A major medical event, such as a stroke. A major psychiatric event or decompensation resulting in extended inpatient psychiatric hospitalization. Or a significant improvement in behavior or physical functioning. And again, the example I provided earlier for the person who was stabilized on medications is a good example. This documentation will be necessary to provide OPWDD for review in decision making to determine whether the person has experienced a qualifying event that would allow for us to be able to complete assessment outside of the usual interval and categorize that reassessment as a significant change in condition. So again, just to quickly review the role and responsibilities for the care manager. For reassessment, routine reassessment, OPWDD is starting with those assessments that were completed in 2016 prior to CCO implementation, and there is no change in the role of the care manager. For those reassessments that are deemed to be significant change in condition, these are related to qualifying events and are outside of the parameters for routine assessment, the role of the care manager is to notify OPWDD that the person is believed to have experienced a significant change in condition, and it can be an improvement or a decline, and we will provide support to guide you through the next steps. If you have the supporting documentation available at that time, it would be helpful to submit. If you don't, there's no worries. We will work with you through each step. And to bring these to our attention, you're emailing us at coordinated.assessment@opwdd.ny.gov. Additional information will soon be made available to care managers, supervisors, quality assurance teams, and CCOs, as well as the public, through our OPWDD website. So as soon as available, we will be uploading additional information. I think at this point what I'd like to do is just take a moment to see what questions have come in.
All right, thank you, Al. So we're just going to mute, and we'll come back and ask you a few of the questions that have come through on the WebEx. Okay, so we have a couple of questions for you, Al. Angie Francis is going to ask them.
Hi, Al. One of the questions that came in was, is there any exceptions to, is there any exempt individuals from getting a CAF, or is anybody in the OPWDD system up for initial or reassessment?
Any person who has previously received a CAS would be pulled into queue for reassessment. We would likely take those situations where there may have been change to the person's status with respect to their receiving OPWDD services into consideration on a case-by-case basis. In terms of more generally, is there any exception to the requirement for the initial CAS? We are working to complete an initial CAS for any person who is receiving OPWDD supports and services. At this time, we're really focusing on those people who are adults, 18 years or older, and are receiving OPWDD supports and services.
Thanks, Al. One of the other questions that we received regarding reassessments was that, there's note that in your slide, hospitalization due to medical or psychiatric needs would be a trigger, but would being discharged due to improvement also be a trigger for a need for reassessment?
Well, I would encourage people to go back and look at the slide where it speaks in more detail to the impact that the significant change in condition has had. If the change in condition has resulted in a change in need, that has also involved the need for the care plan to be modified, I think we are okay and would appreciate having those cases that are not perfectly clear to the care manager run by us. We're happy to review the information and see if the event is qualifying. Generally speaking, a hospitalization followed by discharge may not always result in a change in need.
Good clarification. And I think that segues into another question. Some individuals kind of have an up and down, in their level of care. The question is, every time should this be reported to be determined if there is a need for reassessment, or should they kind of follow the outline in the slide?
I fully understand, and this actually comes up in our presentations and discussions quite often. People are dynamic, and their needs do change, sometimes from week to week, other times from month to month. The CAS is able to accurately capture support needs that are not consistent, that is daily, through the various items in the CAS which speak to behavioral or medical type supports. So for every person that has periodic change in their needs, it may not be necessary or result in qualifying event and need for reassessment for significant change in condition. I really want people to focus on the language here, a significant change in condition, because what we find to be the case for people who are falling into that first group where their needs are just dynamic and changing is that there's already a level of support in place to address that fluctuation. We're talking more about a person who, absent of a particular event or change that has occurred, even over time, does not have or would not have normally had the appropriate level of supports in place, and these would be more likely to be captured in this significant change in condition group and require an updated functional needs assessment to fully understand and support those changes which might need to be implemented. And I would see those as relating to health and safety, staffing levels, et cetera. It could be, again, an increase or a decline, and those are best to be captured and supported by a needs assessment tool.
Thanks, Al. And I know that this wasn't part of your presentation, but a couple questions have come in, and since we have the care managers as an audience, I didn't know if you wanted to provide some clarity. Several questions came in about if a care manager has questions or needs clarification on the summary, the CAF summary, and what they should do when they do have questions or points of clarification. I know this comes up a lot, so I figured you might want to take advantage of pointing care managers in the right direction on this.
No problem. The best starting place for the summaries and review of summaries and questions is we have some pretty significant information available on the website to be sure assessors are reviewing. The summary guidance document is also helpful. We found that in some instances that's resolved the question that was brought to us. But I think as care managers are working through the steps, they're connecting with the person, they're connecting with those who support the person, and there are questions or concerns that are coming up that they're capturing some of that narrative and context as they work through identifying the documents that were also available to the assessor and reviewing those documents. Then at the end of the day, if they've spoken with those who were interviewed, they've talked with the person and their natural supports, and they've looked at the documentation and tried to understand, is this something that needs to be updated or clarified, or is there something about these CAF summaries that still is just not making sense and people aren't identifying with it as accurate? Then the next step would be to reach out to coordinated data assessment, and we'll be happy to dive in deep and get to the bottom of it and work to resolve those questions and concerns as quickly as possible. If a care manager is just seeking additional information, not specific to an individual's CAS, but rather in effort to just be well-informed and educated and has question about CAF summary, we're always available to talk with those care managers. We usually ask that the supervisor also be part of the conversation, mainly for the purposes of getting as much information out to as many people as possible in one call, essentially. If we were to talk to every care manager in the state, that's a large lift. If we engage with a care manager who has a really great question for us, but we have their supervisor present, we can be assured that that supervisor will also communicate that to the rest of the team, as well as their cohorts, and other supervisors would also be well informed. But please reach out to us at Coordinated Data Assessment, and we'll get back to you on those questions.
Okay, thank you very much, Al. Those are all the questions that I have right now.
Great, thanks, Angie.
Thank you very much. Okay, so we are going to move on to our next presentation on the fully integrated dual advantage for individuals with developmental disabilities, also known as the FIDA IDD, our managed care demonstration, and on the care coordination organization's role. So we have Timothy Byers with us. Welcome, Tim.
Thank you. Great to be here. Well, actually, it's not so great to be here. What's prompting this kind of revisit of the FIDA IDD overview is that recently we've had some feedback from the community, families, our FIDA IDD plan, that there seems to be misinformation coming from the care coordination side, and some of it seems to be that there isn't consistent knowledge of the program, and others may be something that, again, is probably not information that's in the best interest of the individual or family. So we want to go through again what the FIDA IDD is, how it fits into the overall scheme of the agency's goals, and how the transitions can be better aided with the care coordinators, the plan, and also when somebody leaves a plan, how to help assist as the plan transitions the care management back to CCO. So basically, you'll see there that the first slide, participation. This really is a joint effort here. We're moving towards a program of managed care and care management as an agency. This involves a seamless work between agencies, services, projects. All of this has to come together. We can't have our families and individuals struggling because of breaks in communication, education, or anything that could be deemed as a selfish interest. We want to make sure that everybody is on the same page here and that we're working together. The managed care program is something that we pushed for to give an all-encompassing project in the fight IDD that not only meets a seamless coordination of the Medicaid, Medicare, and service benefits, but also takes us toward a project that we can align quality with payment. And that's something that we're looking at in all of the areas that we're working on now. The agency has to evaluate projects as they go and see that what we're doing is providing the results that we owe to our individuals and our families. As Amanda mentioned, we are talking primarily today about the FIGHT IDD managed care model. Again, it's a multidisciplinary care planning and care management tool. PHP, like all managed care programs, has provider networks. They have contracted or single case agreement efforts with their service providers, as well as the medical and Medicare side. They tie all of this together, and it's one of the true seamless models, and it's the only one right now operating in the U.S. that ties all of this together for DD individuals. As such, CMS has a very keen interest in the ongoing works of the FIGHT IDD, its implementation, and its success. So the coordination here between our agencies, our providers, all of this is very important to ensure that it works. So, the model itself is a voluntary program. That means individuals can choose to enroll in the FIGHT IDD plan, or they can elect not to. We've had, again, some misinformation on this that's going around. Because an individual or their family is choosing to enroll in the FIGHT IDD program, that has usually come on the basis of meeting the FIGHT IDD plan at an outreach session or talking to the enrollment broker, New York Medicaid Choice, about their options. The care coordination organizations should be supporting individuals in their choice and their selection here. As managed care now encompasses approaching 30,000 of our individuals, the care coordination piece has to be cognizant of the plans that people are in, what benefits are offered by those plans, and how they can assist the families and individuals in achieving what they're desiring to get. So again, very important. Right now it's a voluntary program in the FIGHT IDD. It looks to remain that way, so people can opt in, and we're looking for support for those who are looking to opt in and make sure that the transitions work seamlessly. A little bit about the benefit package. I mentioned that it's a combination that entails the Medicaid, Medicare, and the DD service benefit here. You'll see that it's not just a care management program, which some of the, I guess, incorrect feedback we've heard from the community is that it's being said that you don't want to enroll in the FIGHT IDD, it's just a care management program. Well, that's not true. It's a managed care program for the Medicaid, Medicare, and the DD service field, and it offers individuals an opportunity that they won't get elsewhere. We have approximately 27,000 in mainstream Medicaid managed care plans, but those are a little different in that the DD service program remains a fee-for-service component. It's not billed to the plan doesn't authorize. In the FIGHT IDD, the DD services are authorized via the plan, so it really has the opportunity to make sure that the health and the service worlds are looked at together, and that we provide, again, that global view of care that we really need to show our individuals. The next slide talks about who's eligible. This is an adults project. You've got to be 21 or older. You have to have full Medicaid and Medicare benefits, and you have to meet the ICF level of care. The other piece to this is the region is only a downstate product right now. It's available in 9 counties, the 5 boroughs of New York, Nassau, Suffolk, Westchester, and Rockland. For those of you who are not in those areas, and I apologize for taking you through the FIDA story here, but it's important to know, again, that as our agency's care management and managed care models develop, that this working relationship on behalf of the individuals is extremely important, and it's something that our agency will use to measure our partners by. How do we make things work? Where are the weak links? Where is information falling apart? Again, we have to focus on the individual's choice and the best settings and selections for them. As you're all well aware, the Life Plan is the person-centered planning tool that we're using for the IDD individuals now. It's part of the service authorization, and with PHP, it's no different than working with other providers in that aspect. As I mentioned earlier, PHP authorizes and coordinates the services, and they pay providers. So everything runs through them to approve, and PHP does the payments. We then pay the managed care plan, the FIDA IDD PHP, monthly capitation payment for their efforts. So how do the CCOs come into play here with the managed care FIDA IDD project? It's incumbent upon the individual's care managers to help them select the best product for them. If they don't meet and we've had several people who wanted to join the FIDA IDD, but they don't meet the eligible criteria to come in. It's up to the care managers on the CCO side to help people understand where they could be best served. In often cases, that would be entering into the enrollment of the FIDA IDD plan. With the multiple offerings that they have and the network development, it's important for families and individuals to get into a program that makes the care service tie that much stronger. As you know, a lot of our folks have trouble finding certain specialties. PHP has a very strong dental program. In fact, they have one of the I think most advanced projects with it. They have a group of dentists who provide preemptory visits that these folks can, if they tend to experience angst or discomfort with going to a medical provider setting, and who likes to go to the dentist? Not me. But you go there and you sit in the chair, you start to panic. Well, for folks who have that type of anxiety, PHP has a network project with a dentist that will allow these visits to come there. They can come, experience the office, meet individuals, sit in the chair, and kind of get the experience prior to coming into basically a cold visit session on the dental side. And that's where PHP, as our kind of our flagship managed care project, is making great efforts to kind of tie all this together, and they know what would work best for a lot of our folks. So the management role there belongs on the PHP side. So the support we have through the CCOs is to, again, assist them in explaining benefits and informing the folks of their choices and supporting them when they do make a decision on that. Oh.
I just switched.
Oh, thank you. I'll also point out that for CCOs who want a little bit more information, you can see the FIDA IDD brochure on the link on your screen there. It's the OPWDD NY.gov sites default doc in the Managed Care FIDA IDD PDF. It'll give you a lot of information there, but you can also reach out to the folks at the DDROs for more support on this, or we have a FIDA IDD mailbox where you can reach out and folks in our unit will get back to you on any kind of questions related to the FIDA IDD project. Okay, the care manager role. Again, if they're interested individuals, this is where the CCOs can play an important part in helping people understand who is eligible to enroll in the project, and if it would be the better solution for them if they're struggling with finding network providers, or they really would benefit from the overall care coordination, which most of our folks would. It's something that's important for the care manager to help them work through this process. Now, the processes entails the New York Medicaid Choice program. New York Medicaid Choice is the enrollment broker for New York State's managed care systems. This broker does all of the education and enrollment for the FIDA IDD as well as most other plans in the state Medicaid system. They provide a great deal of information to the individual as far as benefits that are provided. They also have access to plan network providers. So if you have somebody who wants some, as in seeing a special orthopedic a surgeon for a number of years and they want to remain with their provider, you can help them and be with them on a call and call New York Medicaid Choice, and they can say, yes, this doctor is in your PHP's provider network, so that it would be a good fit. They can go through the whole process not only on the Medicaid, Medicare side, but they can also talk about service providers in there as well. So very important to understand that New York Medicaid Choice can not only do enrollments, but they can give support as to the benefits that are available and also PHP's provider network. So how does Medicaid Choice work? They are supporting PHP and our program in doing outreach sessions at community sites. They've done some provider sites where they basically are there to provide an unbiased opinion on, well, not an opinion, an unbiased education on the FIDA IDD project as well as other managed care projects, because not everybody is eligible to enroll in the FIDA IDD, and for those who aren't, they can also explain to them other options. Not everybody goes into a FIDA IDD, nor do they all want to, but there are other options as well as remaining in fee-for-service, because IDD people are currently exempt from mainstream managed care and MLTC, but often their needs are they need an MLTC service, so they can look at an MLTC partial plan that would provide them the personal care they need. Right now they don't need waiver services. They can look at an MLTC partial, and New York Medicaid Choice can give them background information on how the program works, and again, network providers and the MLTC plan can assist them with finding personal care providers. So once an enrollment has been put into play, it goes to Medicaid Choice to basically process the enrollment, and that will trigger a disenrollment from the CCO. This transition kicks off a very important part of the, kicks off a very important part of the program, and we've had some issues here with information not getting to the plan. Once the plan enrollment is set, and enrollments begin the first of a month, so you'll never have a transition in the middle of the month. So with a managed care program, it will always be that first of the month, and within, say, normally a week or so of that enrollment, the PHP, once they know the coming enrollment, they'll reach out to service providers to ensure that they have the latest information, they get the appropriate documentation, and that they get services in place for the upcoming month. They have a continuity care provision in their contract that they have to ensure that we get all the services in place. They'll then do an assessment in the first 30 days, and within 90 days they will have a new life plan constructed. So with this processing of the enrollment, the CCO will need to send the DOH 5235, Notice of Determination for Disenrollment, the NOD, to the individual and their rep, and that basically says that you are disenrolling from our program. That enrollment is taking place because they've opted to go into the FIDA IDD, obviously. As I just mentioned there, the important piece here is that the care manager is integral to our transitioning process, that it helps no one if the documentation is not in place and not handed off to PHP to pick up the care coordination. They have to have everything in place. Upon notification of termination, there are 5 business days. The care manager must supply the ISP, the life plan, the initial LCED, current LCED, and supporting evaluations, as well as a DDP2 and any CAS assessment information if applicable. So one of the things that, again, we've seen so far is that this is not always the case, that we are not seeing this timely. This has to improve, and we want to make sure that these items get transferred quickly and that this project can be strengthened by the cemented handoffs, if you will. So, transition to the FIDA IDD. The FIDA will use the most current plan of care to preserve the continuity. Again, I talked a little bit about that they have 90 days or until a new life plan is in place. The option is up to the individual. Basically, the individual enrolls in PHP. PHP keeps the same services and then does the assessment and the construction of the new life plan from the PHP side. The individual then can choose to change services. If they want to make an amendment to their current service world prior to the 90 days, they can certainly do that, and PHP would be required to implement this. It's, again, back to what I just said, very important that that documentation is in place and that PHP has it in their hands so they can provide the necessary programming for the individuals. The CCO participants have a choice to voluntarily enroll in the FIDA IDD. As I mentioned, it's a voluntary managed care product. The care manager has to ensure that when individuals are asking about the FIDA IDD, it is mentioned to the individual that they know it's a voluntary product. There have been some, again, streams of misinformation saying, oh, you go in, you can't get out. Or it's mandatory that you enroll in the FIDA ID. It is not mandatory. And because it's a voluntary program, you can opt out. Again, monthly program, you would opt out, according to pull down, the month that would be the next in line. So if a person were to say, oh, it just isn't working out for me, or my clinic dropped out of PHP's network, so I want to come out, they would transition out, again, according to the managed care pull down, which is based on the 20th of the month. So if somebody wants to disenroll, their request comes in by the 20th of the month, they can be disenrolled for the first of the coming month. If it's after the 20th, it's going to go effective the month after the month of the request. So it would be, so if you request it August 21st, you would not come out on the September 1st, but October 1st. Again, it's a systemic pull down with that process. The care management procedures. At the time the CCO receives notification, the care manager has to send all the necessary documentation. We talked about the ISP or life plan being pushed forward, the LCED determinations, and there is a mandate of 5 business days to do this. Again, we're hitting this because we're not seeing it followed in every case. Okay. The CCO must process the CCO2 disenrollment and choices the month prior to the FIDA enrollment. This kind of ties everything together in the OPWDD system. The system I'm talking about with the enrollments for the FIDA IDD takes place in the eMedNI system, but it also has links back. It will close out the eMedNI link for the CCO as they enroll into the FIDA IDD. Now, if somebody is disenrolling back to the CCO world, if they're coming out of the FIDA IDD, situation has changed, the individual or the family want to go back to the fee-for-service world, it's incumbent upon the plan to kind of take on the same role of responsibility that the CCO had when somebody was incoming to the FIDA IDD. PHP must share the information back to and help the individual select the CCO. Most often people go back to the originating CCO, but again, it's their choice. They provide the information, and then PHP would then share any documentation that has been accumulated during the enrollment period. One of the problems that we've had on the FIDA IDD side is that once the decision is made to disenroll, people are thinking that PHP calling them to say, we'd like you to help you select a care manager or CCO, people think that they see that it's PHP calling. They think they're being done to stay in the plan. They're not. PHP is not allowed to badger people or to press people to stay enrolled. We take that very seriously. But individuals and families, once they decide to disenroll and the transaction is processing, are often concerned that this is a call to kind of like push them to stay in the plan, and it's not. So sometimes there are issues with getting the care coordination back into place. And as you know, particularly for the waiver folks who have to have that CCO in place, it's sometimes difficult to get that cleanly done because of some apprehension by individuals. So again, some of this information can be shared early on prior to enrollment, that if, again, voluntary program, if you decide to leave, PHP would then help you select or come back to the CCO program that you left. These are very important issues. And just as the CCOs have 5 business days, PHP, the FIDA IDD program, has the same restrictions on it. It has to be done within 5 days. So, talked a little bit earlier about the managed care spectrum that we now are approaching 30,000 people overall. The FIDA IDD has about 1,400 people enrolled in it in our 9-county demonstration project. But as managed care grows, and this is the vehicle that the governor has chosen for delivery of the Medicaid services in New York State, we are going to continue to utilize care management and managed care programs to get out the best coordination of services and health care, as well as being fiscally responsible. We need to have models out there that support and deliver the best quality of care. And again, this is the vehicle that the state has chosen. So it's important to CCOs to be aware of managed care enrollment, particularly for somebody who's in a waiver and they want personal care. They can be told, well, you need to go into MLTC. If you look at the slides here, there are certain programs you can't coexist in. MLTC partial plans cannot have folks who are in the waiver. They can take DD individuals in their program, but if they're waiver enrolled, that cannot coexist. HARP, the Health and Recovery Plans, is another model that is basically a BH-centered program that has intensive care management through their health home. Those can't coexist with our folks. The mainstream model I talked about a little earlier is a model that keeps the DD service side as fee-for-service at this time. So those can certainly coexist there. But it's very good for CCO care managers to be aware of what type of program that somebody is enrolled in, or if they might benefit from a program that can help support them. So CCO need to be proactive in recognizing managed care or health home enrollments. So it will, I think, dispel a lot of the confusion that goes on as people transition, and the growth of managed care and other care management programs, such as the health homes and the CCO health home, as they kind of saturate New York State. It's something that we continue to see issues with crossovers or programs, and it's not just on our side, but the health homes on the DOH side, not understanding, or we get conflicting enrollments because individuals and families can be overwhelmed by, oh, yes, I have somebody here who comes in once a week, and they can't, sometimes because there's so many things going on that they have home health aides, they have a care provider, they've signed up for what they thought was a CCO when it was actually a DOH health home, and then we get 2 consent forms coming in. It's important for the CCOs to understand the world we're operating in now, and to ensure that when they are talking to individuals that they talk about their needs, and also what programs are you currently working with. And it's always good to understand that so you can help them in the best possible way. So you'll see some resources here on the back side. It talks a little bit about the FAQs. We also have information on the FIDA, and the FIDA mailbox there. If you have questions, you can submit to us. Again, to tie this all together, we've hit an uptick in issues where families and individuals, PHP has also had issues where they've brought some things to our attention, that some of the care managers are either making uninformed recommendations to families, or they're making recommendations that are inappropriate. They're telling people that they can't be in the waiver and be in PHP, or you're locked into PHP forever. This session here is kind of to make sure that the groundwork is laid. Because we've seen this recently, we're now going to start escalating individual incidents to the CCO management, that we will identify the individuals who are involved in incidents on the care management side, and we will push that up the chain so that we can get this dealt with. This is a very exciting time for OPWDD as an agency and the people we serve. We can't have misinformation chipping away at what we're trying to do. So, that said.
Okay, so we'll pause for a moment to review the questions that have come in, and then we'll be back online in a moment. Thank you. Thank you so much for your patience. Angie is going to ask some questions for Tim to answer.
Okay, great. We did get some great questions. So, Tim, can you just take a minute and clarify when an individual enrolls in the FIDA, who will then provide care management services and, that whole exchange?
Great, thank you. And that's a great question, because it gets at the fundamental issue here of the PHP. Once you enroll in the FIDA IDD program, that care management belongs to the FIDA IDD plan. So PHP has a 2-tiered system of care management, a little bit different for their Willowbrook situation, but that's a tale I won't go into at this point. So you'll have a case care manager and a care coordinator working on the individual's Medicaid, Medicare, and their service coordination. So it definitely responsibility of PHP once they transition from a CCO to PHP. And again, as we just mentioned, if somebody chooses to disenroll, it's incumbent upon that plan to ensure that to the best of their ability, that they get somebody to indicate their selection, and they can smoothly transition back to a CCO. It's definitely traumatic, I think, to some folks that they lose somebody who's been working with them for a while. But again, we're looking at the benefits here, that with the FIDA IDD, it's a heightened care management program, but it's also that coordination of the medical and the service world, that you having somebody who helps not only pick the life plan information out, but they also know that Tim has to have certain providers in their network and that they need to be close to his day hab. You know, there are things that the FIDA IDD can do that really nobody else can, because they have access to the medical side, the health side, if you will, as well as the DD side.
Thank you. Is PHP currently the only provider of FIDA IDD services at this time?
Yes, they are. There is only the one plan. It's, again, in the Nassau, Suffolk, Westchester, Rockland, and New York City. It's the only one in the country that is operating the triumvirate, if you will, of the Medicaid, Medicare, and the DD service world. We've had calls with other states and CMS, and they're curious as to how it's working, pitfalls, transition issues. So a lot of states are looking to us to see how it works.
Great, thank you. Can you just kind of highlight the differences, the significant differences between CCO and FIDA IDD, and possibly, you know, how care managers can help individuals to notice what the differences are so they can best inform and help people to make an informed choice?
Thanks, Angie. That's a good question. And you really need to look at the FIDA IDD as it is a managed care model. They have care management in it, and as I mentioned, it's two-tiered. They have a care manager and a care coordinator, but it's also the health model that's in there too. They not only authorize and pay for DD services, but they're also responsible for the Medicaid and the Medicare. They have to do the health part of it. They ensure that you can get the care you need. Often our individuals struggle in certain areas getting appointments. It's difficult to find providers who deal adeptly with our folks, and PHP with a core team that is DD-based certainly understand this, and they've really developed a strong network in the downstate area and pulled together a team that works very hard to ensure that all the health care needs are met and that the DD service needs are met, and when there needs to be some type of affiliation, because their life plan looks over all of that. They are looking to ensure that health and service is brought together and for the benefit of the individual.
Great, thanks, Tim. Is there a timeline for FIDA IDD to expand out of this pilot area and go to other parts of the state?
Right now there isn't. The demonstration runs through the end of next year, and we are looking at options. There, of course, is the option to extend the demonstration. There are other, as many of you have probably heard, there are many other opportunities that we are working on now as an agency. So a lot of that is still kind of in development. So there have been discussions on, again, extending the project. Does the project need to go to a broader area of coverage? These are things that we're working with PHP on, but also our partners with CMS and the Department of Health, because they basically are the Medicaid agency for the state and kind of own, if you will, the managed care models. But we developed, obviously, the FIDA IDD. It's something that we're trying to sort out what would be the best option for our folks. So a lot of these things are in discussion and not quite ready to hit the street, so we still don't have complete answers on that.
If an individual chooses to enroll in FIDA IDD, are the array of self-direction services available through that model?
Yes, you can do self-direction in PHP, their self-direction model has been growing. One of the things that I'll mention is that they have robust networks in not only health but on the service side. But not every provider of every type is in PHP. They will offer single case agreements for providers who choose not to be in the network. They'll say, well, you know, we only have, you know, Tim as far as somebody who's enrolled in your plan, so we don't really want to be a network provider. So PHP will then say, well, we'll do an agreement where we'll just contract with you and pay you for services for Tim. So they'll do their best to make sure that they meet the needs of the individual by looping in and contracting with providers. But it's not to say that 100% of our providers on the health and service side are in there, but the programs are all in there.
Okay, we did get a question. Tim, can you talk a little bit how individuals who are Willowbrook class members and what FIDA IDD kind of looks like for individuals of the class?
Sure. We have approximately, I think it's like 150 now, Willowbrook individuals who are enrolled in the FIDA IDD. We work very closely with the CAB, and they refer individuals to us who would have their needs best met through a comprehensive program like the FIDA IDD. Once, as with anyone else, if you enroll into the FIDA IDD, the care management comes to the FIDA IDD program, and the care manager would transition out of CCO. This is true of the Willowbrook folks, except for those in ICF. In that case, those service coordinators who work on the, and I can't remember the initials for the acronym for it, but those Willowbrook service coordinators, I don't know if it's the WSC or the WCS. It's the SC, is it? Yeah, they're the ones, if they are working with them in an ICF, they'll remain in place. However, others who are not in the ICF and represented by the CAB, those will go over to, completely over to the FIDA IDD program. And even those with the Willowbrook ICF status, PHP still has a care management piece in place with that. Again, they're the authorizing entity here. They are responsible for care coordination and service coordination. Now, there was a question that was like, is this a commercial for PHP? No, this is really kind of an explanation of this is an agency model that we are standing behind, and as such, our individuals out there in the CCO and care management world need to be behind our projects and to ensure that individuals have an unbiased opinion on choosing what's best for them, and that you are to present all the options. FIDA IDD is not always the best option for individuals, but it's to be presented that way, that there is an option for you if you're in that 9-county area. So is it a requirement that you have to bring this up? It's highly recommended that when you're discussing options and where somebody is going with their plan of care, their services, their health needs, as a CCO health home, you're expected to bring forward the option to them.
Thank you, Tim. I think that covers all of the questions that we have right now.
Thanks so much.
Excellent. Thank you very much, Tim. Okay, so we went through questions, and we're going to circle back to our information from the hot topics, and this is what we will conclude with today. So we'll go through the rest of this information about disenrollment and take any questions that people have on this. So this is a repeat of the slide that we went through earlier regarding voluntary withdrawal from CCO, and I just want to highlight from a question that had come up related to this is with the third reason, withdrawing from CCO enrollment and is completely withdrawing from care management services, that disenrollment transaction goes to the DDRO for verification and approval, and there will be notification through choices when that approval is done to remove the person at the end of that month that the approval is provided. The NOD does not go out. That DOH form, the DOH 5235 NOD, is not sent until that DDR approval occurs. So somebody should not be receiving an NOD removing them from the CCO program prior to the DDRO going through their process of ensuring that the person does truly wish to withdraw from CCO. So that is the order of that, and you should be working closely with your DDRO CCSL on that process. So disenrollment from CCO, the reasons that somebody would be disenrolled is that they no longer are enrolled in Medicaid, that they live in a non-qualifying setting, that they're enrolled in another care management program, and no longer reside in New York State. So these are reasons that the care manager or CCO staff designated for this function would go in to choices and to disenroll, and then the reason why somebody would be removed from the CCO program because they are no longer meeting the enrollment qualifications for the program. So the steps that the CCO takes is to, after this information has been verified, so, you know, if it's just a Medicaid issue, obviously the care manager should be working with the person and the family to get their Medicaid reinstated. With a non-qualifying setting, that you know that they have moved to that setting or that they have engaged with that new non-qualifying service as listed in the policy manual, so that all of this information is verified and confirmed beforehand to support these actions, such as enrolling in another care management program or when somebody has moved. So after that has been verified and you have you know, the proper documentation to show that that's happened, then you would submit that CCO2 form and choices. That the NOD, the 5235, would be generated, uploaded to choices, so it would be saved to the supporting documents in choices. It would be sent to the individual parent, guardian, or representative, and that the DDRO will be notified. So for every NOD, those should exist in choices in the supporting document, and the DDRO should be notified of that NOD. The disenrollment is effective the last day of the month, except for the reasons lives in a non-qualifying setting. So if somebody lives in a non-qualifying setting, the disenrollment is going to, it'll allow you on the CCO2 form to input that date, and you really need to make sure that that date is entered for the day prior to their enrollment in the non-qualifying setting. So if, for example, somebody is moving to an ICF setting and they move on September 12th, then they should be removed today so that that enrollment can occur on the 12th as it needs to. So these are the reasons for disenrollment from CCO. You'll notice that that form that was indicated on this slide, the 5058 or the 5202, does not need to be signed in these situations because somebody is not voluntarily withdrawing from your CCO. They're being disenrolled because they no longer qualify for the service and should be notified as such. So to make that clarification that people do not need to sign the disenrollment forms, the 5058 or the 5202, if they are being disenrolled for these reasons. Another reason for disenrollment from CCO is if an individual has deceased, if somebody passes away, the steps that should be taken is to, once that has been confirmed, to process the CCO2 form in choices. Do not generate or send the DOH 5235 disenrollment NOD to the person or the family or representative. The DDRO must be notified of this, and the disenrollment is going to be effective the date of death. So this, again, is a reason that will allow for input of a date versus it auto-populating to the end of the month, and it must be entered accurately for the date that the person passed away to ensure that other actions can occur to properly address in our system that the person has passed away. The reason individual no longer meets level of care criteria or is no longer OPWDD eligible is another reason that somebody must be disenrolled from CCO. So again, similar to somebody voluntarily choosing to end all care management services, this is a reason that goes into the queue for the DDRO to verify and approve. So again, that NOD 5235 should not be sent to the individual or their family until that verification and approval has come from the DDRO. The steps to take when somebody no longer meets level of care or is no longer OPWDD eligible is that you would again process that CCO2 form, and it's going to auto-populate to the end of the month after it's approved by the DDRO, and this again is going to have that submitted status versus process because it is submitted for approval to your DDRO. Once the DDRO follows up on confirming that the individual no longer meets a level of care or is no longer OPWDD eligible, they are going to approve that. So the CCO should be monitoring choices for the disenrollment confirmation. And once that confirmation is made by the DDRO, then the individual will disenroll at the end of that month. You'll see that action occur. And once confirmed, the CCO must generate that NOD, the 5235, and upload it to choices to the supporting documents, distribute that to send that to the individual parent, guardian, or representative, and to also notify the DDRO of that disenrollment in the NOD. Disenrollment, again, as I said, is effective the last day of the month. All right, so we are going to take a moment to see if any other questions have come in about any of this information, and we'll be right back. Okay, so overall, we had a couple of things come in, and just overall, when disenrolling somebody from CCO, if you have any questions, please reach out to your CCSL, that their contacts are listed on the OPWDD website under Care Coordination Organization. You'll see the contacts for the CCSL. There was a question regarding non-Medicaid care management, and that is a service that somebody would be enrolled in, and that is authorized by the DDRO. So if you have any questions about that, I would encourage that you reach out to your CCSL. As well as any of the more specific, case-specific questions that come up of having issues with getting in contact with somebody and things like that, of reaching out to your CCSL for assistance in how to deal with those specific situations, as well as how best to notify your DDRO of the NOD process. Of notifying when somebody has been disenrolled and that NOD is now available in choices. Okay, so I just want to thank everybody. We had excellent attendance today, and it just continues to improve, so we absolutely appreciate people taking the time out to attend and get this information. As I said at the conclusion of today's presentation, a SurveyMonkey survey is going to pop up in your browser, and we ask that you provide some feedback on today's presentation topics, presenters, and future topics that you think would be helpful. Our next conference is going to be on December 11th, and as always, that information is going to be shared through the advisory, a reminder of the registration being open. It is open at this time in SLMS, and you can go to SLMS from the link below, but we'll also be sharing agenda and materials through the Care Coordination Advisory. Thank you, everyone, very much for attending today, and have a great afternoon.